Welcome to The Whole View. I'm Stacy Toth of Real Everything, and I'm here each week to dive deeper into how we can find happiness and health inside and out through self-love, body positivity, and discovering new ways to be our best selves. Before we get started, a reminder that this podcast is for general educational purposes and is not intended to diagnose, advise, or treat any physical or mental illness. And while Dr. David is a medical professional, he's not yours. So we always recommend that you see a licensed health professional accordingly. That said, I would love to introduce you to Dr. David Clarke, who is the president of the Psychophysiologic Disorder Association. I'm going to abbreviate it PPDA going forward so I don't have the tongue twister. And it is a 501c3 health education nonprofit advancing the diagnosis and treatment of stress-related medical conditions, which we've talked a ton about on the show, and I didn't even realize that there was a name for this. So Dr. Clarke holds an MD from the University of Connecticut School of Medicine and is a board-certified internal medicine and gastroenterologist, is what I'm guessing.
You got it.
Excellent. He has successfully diagnosed and treated over 7,000 people who had no explanation for their pain or illness from a diagnostic testing perspective, though obviously those symptoms are real. And so his organization's mission is to end the chronic pain epidemic. And you can learn more from David and his work at endchronicpain.org. But David, I'd love if you could maybe introduce yourself and a little bit about how you got into this work.
Yeah, thank you so much for your interest in this work. I was very traditionally trained. I went through the first 7 years of my formal training with a focus on organs and structures, as physicians and most medical clinicians do. I was very successful in that area. I got an award for excellence in medical school. I got into a top hospital university residency program. Was passing my board exams with high scores. So the last thing I expected was to run into a patient I didn't know the first thing about diagnosing or treating. And that happened in year 8 of my formal training. It was a patient with a severe gastrointestinal condition, which I was in training to learn about becoming a gastroenterologist. She'd actually been referred from another university because they couldn't figure out what was wrong with her. And we did some specialized testing, and we were convinced that test was going to show what the problem was because, as far as we were concerned, there was no other possible explanation. But the specialized test was normal also, which shocked my department chair and I. And it was left to me to do her exit interview and basically tell her she was going to have to live with this. But I asked her about stress. Other doctors had asked her, and she didn't really have any. Her life was going along well. She was happily married, 2 kids, worked half-time in a bank. Not really nothing stressful. But then I asked her about stress earlier, and my intent was maybe she had a trauma of some kind 2 years ago that could have triggered this severe illness that she had. But she interpreted my question to mean the remote past and started telling me about having been sexually abused by her father. And that took place at least 25 years in the past. I didn't see how it could be connected to her illness, but it gave me an option for something else to do for her, which was to connect her with Harriet Kaplan, who was a psychiatrist at UCLA at that time that worked in the area of mind and body illnesses. And I didn't think anything would come of it, but I ran into Harriet 3 months later in the elevator ride that changed my career. And I asked her about this patient, and Harriet had cured her with less than 3 months of counseling. And that blew me away. It upended my world that you could alleviate a serious physical condition and completely real physical condition just by talking to somebody. I had no idea that was possible. So I wanted to be a complete doctor. I had Dr. Kaplan teach me her framework for how she thought about these things. And make a long story short, it ended up being something I used for 5 or 6 patients a week for the next 25 years, over 7,000 people with no organ disease or structural damage to explain their very real symptoms, which were instead being generated by the brain because of stress. So long-winded answer, but it was just came as a shock to me and was incredibly rewarding professionally.
I love that you call it the elevator that changed your career, but also changed the lives of a lot of people in order to learn about this. And I have found as someone with autoimmune disease, and I became a foster mom of severely traumatized youth, that in that training and learning and unearthing all of that, I realized a lot of my own control issues and the things that I was holding on to so tightly in my body really had a lot to do with my own past as well. So it makes a lot of sense for me. I'm wondering if you can share more about, in general, what is PPD, right? Like, what are some of these symptoms that might be under the umbrella of when you're talking to a patient, right? Like, when are you like, let me ask some more questions?
Yeah, well, I like to ask these questions even in the beginning of an interview, the first time that I meet someone, if they don't have a very obvious explanation for their condition. If somebody comes in and they've got yellow jaundice, for example, then they've obviously got a serious problem with their liver or biliary tract. And I don't get into this discussion, but other people, I like to do what I call a stress evaluation and find out stresses, both past and present, that might be going on. And the kinds of symptoms that people can get from this are literally from head to toe. It can be migraines. One of the board members of our nonprofit was absolutely debilitated by migraines, could hardly leave his house for 7 years. Ringing in the ears, dizziness, visual disturbances, difficulty swallowing, pseudo seizures, brain fog, many cases of chronic fatigue, many cases of long COVID, irritable bowel syndrome, which was obviously a big one in my practice, fibromyalgia, functional neurologic disorder, complex regional pain syndrome, numbness and tingling in the extremities, joint pain, low back pain is absolutely huge. There was a recent paper that found that 88% of patients with chronic low back pain actually had a psychophysiologic disorder, and the meaning of that term is it's a blend of psychology and physiology. It's a mind and body, it's brain generated symptoms that are just as real as symptoms from any other cause and can be just as severe, just as numerous, and can go on for years or decades. One of my patients had these symptoms for 79 years, and yet she was successfully treated. Another patient was a teenager whom I was asked to see in the hospital on their 70th day, and they were getting morphine around the clock for unexplained abdominal pain. And I'm reviewing the chart, looking back over the previous 18 months of this kid's illness. They had seen 6 other GI doctors already, but that was also brain generated, and within 30 days, they were off of all the opioid medication. The only common denominator in the nature of the symptoms, and I should point out pain in the female pelvis, bladder spasm, genital pain, that's also in there. But the common denominator is people can have commonly do more than one symptom at a time. So people with irritable bowel and fibromyalgia, or low back pain and migraines. The more symptoms that you have, I just got an email from somebody yesterday. They've got 8 or 10 different symptoms, and that it's very hard for a single disease, even an autoimmune disease that can affect the whole body, to create that many symptoms in a person.
I think some people may hear psychophysiologic and pass it off flippantly as psychosomatic. How would you define the difference?
Well, they are synonyms for each other, but psychosomatic has so much baggage associated with it. And the baggage has to do with the false assumptions that many of us, probably most of us in healthcare education, have been taught. And these false assumptions are that if it's psychosomatic, that means it's all in your head, that it's imaginary, that you can't really diagnose it, that it doesn't affect that many people, that it's really not part of what a healthcare professional should be dealing with, that your best possible outcome from this is that you're going to have to learn to live with it. that it happens to people who are neurotic and can't handle their own stress. Not a single one of those assumptions is true, and yet to this day, those are the implicit and explicit ideas that are conveyed to healthcare professionals, and from there conveyed to patients. And not only are those assumptions false, but in most cases, the exact opposite is the truth. The symptoms are real. They can happen to anybody. They can be diagnosed correctly if you know what to look for. My patients are far from being neurotic. They're actually mentally stronger than average because they've had to cope with a lot more stress than the average person. And they're my heroes. They're capable of handling things that would bring most people to their knees. That very first patient that I mentioned, her father hadn't sexually abused her just once or twice, which would have been bad enough. He sexually assaulted her hundreds of times. And yet, if you worked alongside her in the bank, you'd never know. If you were her neighbor, you would never know. People don't have medical alert bracelets that say, I was sexually abused by my father 400 times. They look and sound and talk like anybody else. They just have these terrible illnesses that they come to the doctor for, and the doctors typically don't know what to look for. And so it gets missed, and people carry on with these illnesses for a long time.
Science has been able to do a lot of validation towards that, um, all the assumptions that you were talking about earlier, right? Like the psychosomatic versus it actually being a problem. And I think one of the things that I've been trying to educate on and help people understand more is our nervous system and how important it is in driving actual physical symptoms or physical changes within our body based on how we're processing things. And I'd love if you could talk a little bit about the actual mechanism, the physical mechanism in our body that drives BPD.
Yeah, it's been shown through numerous studies now using a device called a functional magnetic resonance imager that the circuits in the brain are actually different in these conditions. And it's been studied in somatization disorder and fibromyalgia and irritable bowel and a number of others, that the circuits in the brain are actually different. And what that turns into is that signals from the body, which are always coming into the brain and being processed, they are being processed in a way that is interpreted as painful or that results in signals going back into the body that produce symptoms like constipation, diarrhea. One of my patients had complete paralysis of his stomach from this. So it's all absolutely real and physiologic. The circuits are fundamentally physically different in people that have this condition in their brains, and that this has come about because of stress in the person's life, past or present. But at the same time, with the new techniques of what I call pain relief psychology, which incorporates several different concepts, there are roughly 3 different forms of this, which we can get into if you want, but I use the umbrella term of pain relief psychology. And when you use that, the circuits can physically change back to a healthy pattern. We first saw that in a case report in 2003 in a patient with severe irritable bowel. Her brain circuits changed after psychotherapy of this type. And then more rigorously, the Boulder back pain study published in 2021, I believe, from Boulder, Colorado. They did MRIs on everybody before and after they got the pain relief psychology, and the circuits physically changed as a result of that talk therapy.
I'd love if you could share about those pillars. I think the sorry, if that's unclear. I'd love if you could share about the 3 different areas under that umbrella that are included.
Yeah, they all have their technical terms. Pain reprocessing therapy is one. That's the simplest. Emotional awareness and expression therapy is another. Just had a wonderful paper published from the Los Angeles Veterans Administration Hospital about that. They got incredible outcomes with a very tough group of older male veterans with chronic pain. And then the third type has really got a long-term, intensive short-term dynamic psychotherapy, which has been developed in Canada and numerous papers published about that show far more effectiveness than the traditional cognitive behavioral therapy, which is the most widely available form of psychotherapy in the United States. Cognitive behavioral therapy, unfortunately, doesn't work very well for people with psychophysiologic disorders. You have to get into other areas. And what these three types of pain relief psychology have in common is that they are, number one, aiming for relief of the person's pain or illness. They're not just trying to help you live with it. They are actually trying to alleviate it, and they're successful the majority of the time. The second thing that they do is shift your attention from the place in your body that is having the pain or illness, shift your attention to the brain and try to figure out what's going on there, because it's the brain that's generating these symptoms. And the brain is doing this because of stress. And so we need to do what I call a stress evaluation to find out what is the stress or stresses that have been producing this. And then finally, we're looking at uncovering emotions that people have that they're not fully recognizing.
And people would be able to find more information about some of those solution-oriented approaches at endchronicpain.com, right?
.org, yes,
.org.
endchronicpain.org. Yeah, we keep a collection of resources there. We describe books that we believe are evidence-based, that are self-help books for patients, including my own, which is called They Can't Find Anything Wrong. And we have one that's written for professionals, but it's jargon-free, so people who are interested in the science can read that. It's called Psychophysiologic Disorders. All the royalties from these books go to support the nonprofit, so I don't take any money for this work myself. And then we've got lots of other things. We've got a pair of webinar type courses on the website that are, again, aimed at professionals, but we deliberately kept them jargon free so anybody can take those courses. We've had a couple of conferences with roughly 20 speakers in each of the last couple of years that are recorded. And we've got a live conference coming up that we're very excited about, September 26th to 28th in 2024 in Boulder, Colorado, that's selling out very quickly.
I love that the work that you do is supporting not just the nonprofit work, but also scientific studies. One of the things that I saw on your website was that due to the funding that comes in through the organization, you were able to do what became the 2021 randomized control trial through the University of Colorado, Boulder, where doing that functional magnetic resonance imaging that you were talking about earlier to produce results showing that with placebo versus with the proper treatment, individuals are then able to have better health outcomes. And oftentimes we have individuals on the show who understandably are trying to earn a living, right? Like everybody has to pay their bills. And so they're talking about either their books or their websites or their coaching or whatever. And I think I want to highlight that the work that you're doing is supporting a nonprofit organization that is also funneling money into studies to show and prove through clinical trials that this work can help individuals have better health outcomes. And I think the hard part for me when I think about this is that everyone is looking for relief, right? And like people have these very real physical symptoms and are in pain for oftentimes many years, and they're seeing doctors who are leaning into the training that they received. As you said, you didn't have any training on this, and medications and different kinds of things that can have side effects that then you need more medication, and you get on this hamster wheel, all avoiding the trigger or the trauma or the stress or how your brain is processing something. And oftentimes people never pause to say, let's do this analysis, the stress analysis that you're talking about. And so I hope that with your conference and the work and the different things that you're doing, that more medical professionals can learn how to incorporate some of the science-backed, clinical trial supported information, because it will be life-changing for a lot of people.
Yeah, it's not only life-changing for the patients, but it's career-changing for the doctors who learn this too. There was a psychologist in a medium-sized city on the East Coast who took one of the courses that's on our website and was so taken with that she started using the techniques in her practice, which was embedded in a family doctor office. And she was so successful with that, she got the interest of three of the doctors in her clinic, and she taught them using the same course materials. And they started using it in their practice. It just transformed what they were able to do for these patients. 40% of the patients who come to a primary care doctor have a psychophysiologic disorder. So before these doctors learned how to do this, they were just a source of frustration and frankly burnout for the doctors. But once they learned that they could turn these situations around and alleviate people's symptoms, they absolutely loved it. One of the doctors took me aside at a conference and said that these ideas had put the joy back into her work. That was just wonderful to hear. And they got so enthusiastic about it. They have since, in the following 2 years, taught 70 other doctors in their community how to do this. So we promote these ideas on that basis as well, is that it's career enhancing for clinicians.
I love that. What a great story. I'm wondering if we can talk more about because I do have listeners who love the science. Most of us are not medical professionals, but a lot of us are in the wellness space in one form or another, and I think benefit from this type of education. And PPDA provides what you call a bibliography of scientific references, compiled over 200 relevant research papers, grouped into 8 different categories. And I'm wondering if we can talk through what those 8 different categories are, just at a high level. So I think we've talked a lot about the psychological treatment aspect in terms of alternatives to CBT and some of the other techniques. But one of the other areas that I've talked a lot about on the show is ACE traumas. We had someone from the ACE Trauma Network come on to explain how people who experience those and I'll put a link in the show notes for listeners if you haven't listened to that show. It's really beneficial, and things that you might not realize are traumas in your life, like a parental divorce or different kinds of things when you're younger, can affect your health outcome as you're older. So I'm wondering if maybe we can talk through that and then some of the other categories that these scientific papers are grouped in.
Yeah, I should probably start with just a little more detail on the Boulder back pain study, because the first category in the bibliography is about psychological treatment of these conditions. And it's interesting how that study came about, because we'd been talking to them for a while about doing a formal study of the techniques that my colleagues and I have been using in some cases for decades. I started doing this in 1982, for example. And they were frankly skeptical. The idea that, number one, stress could cause serious physical illness, and number two, that you could talk to somebody in a way that would alleviate that, it strikes most people as a fantasy. But eventually, enough of us talked about our personal career journeys, and they said, okay, we'll study this along with another study we're doing of the placebo effect, but you have to fund it. And so we went to our community and said, look, we need money if we're going to ever subject our ideas to a rigorous scientific evaluation. This is our big chance to do that. And we got over $100,000 donated by over 500 people from 24 countries and paid for the study. And they were still skeptical, said, we're going to do it, but we don't think it's going to work. And we'll see what the data shows. And what we did was we took 3 groups of 50 people with an average of 10 years of low back pain, and 2 groups were the control groups, and 1 group of 50 got one of the forms of pain relief psychology. Just 8 sessions, 2 sessions a week for 4 weeks was all they got, and they had an average of pain of 4 out of 10 on a scale of 10. Their pain was an average of a 4 going back for 10 years. And in 1 month, their pain scores dropped to 1 from 4. And that was all they got. They just got the 1 month of treatment. And then we followed them up for another 11 months to see, is it all going to come back? Is it going to be a giant waste of time that we gave them this treatment? And the answer was no, not at all. Their pain scores on average for the 50 people stayed around 1. Most of them had a pain score of 0. This is after 10 years. And even after 11 months, it didn't relapse. And as you mentioned, they did the fMRI studies of their brains, and their brains had physically changed in response to just 8 sessions of this after 10 years. So that was a huge success, and it unlocked a lot of research funds. And there are now studies going on all over the country. We've got Halifax, Boston, Detroit, Los Angeles, and more being done in the Denver area. So we're going to see a lot more research published in the next couple of years. So the bibliography is up to, I think, 230 references, as you said, divided into 8 categories. The first of which is the psychological treatment studies. But the next one is the ACEs and trauma. And that was a majority of my patients turned out to have adverse childhood experiences. And it turns out the more of those that you've had in your life, the more likely it is that you're going to suffer healthcare consequences as an adult. And one of those is chronic pain. And the non-pain forms of psychophysiologic disorders, also like dizziness or gastrointestinal problems, swallowing difficulty, visual disturbances, all of those that are not pain also can happen. The one issue with there's a standard ACE questionnaire, and it's 10 items long. And the issue with that is that it's both too long and too short. It's too long because it's 10 questions, and that's tough to use in a busy primary care environment. And it's too short because it leaves a lot of things out. Even though it's 10 questions long, there are lots of childhood adversities that it doesn't specifically ask about. So I boil the whole thing down to one question for my ACEs screening. In my written screening questionnaires, what I would do is I would say, if you learned that a child you care about was growing up exactly as you did, how would that make you feel? And I give people 4 choices. They could say, I'd be happy if a kid I cared about was growing up exactly as I did. Or I'd be neutral about it. Or I would be sad or angry about it. Or I would be very sad or very angry. It turns out when you correlate that with the full 10-item ACE questionnaire, the more sad or angry you would be about a kid growing up the way you did, the higher your ACE score. So that one question captures a huge amount of information about what the person's childhood background was like. And then we can go from that question to getting specifics about exactly what did happen to you and its impact later on personality traits, repressed emotions, and triggers.
What a powerful question, and so smart to ask. I have so many things to say about that, but I will just reference people back to our ACE show because we go into a lot of detail on that. And I think it's really worth listening to, not just from the information that we're talking about today, but in terms of increased risk of heart attack and like severe kind of health outcomes to be aware of and to look into. And like I said, your definition of what you think big T trauma might be oftentimes doesn't translate. And I think that's a great kind of way of thinking about it is how do you reflect on your childhood? And maybe you think, well, my parents divorced, but other people had it worse. Like that doesn't incorporate how you're holding those feelings in your body, which probably leads us to the third category, which is pain perception. Can you talk a little bit about that and those studies?
Yes, I should. You prompted me to remember that the difference between big trauma that people recognize, like physical and sexual abuse, and little trauma, which can be just being made to feel like a second-rate human being. It turns out that the long-term impacts of those are usually the same. If your self-esteem was knocked down on a long-term basis, it doesn't matter how it was done. The long-term impacts in terms of stressful personality traits like perfectionism and self-criticism and poor assertiveness and a tendency to choose partners in relationships that are less than fully supportive, low self-esteem, limited self-care skills, all of those things can come about from big traumas or little traumas. As long as the impact on your self-esteem was adverse, the long-term outcomes can be the same. And triggers, and which are people, situations, or events that are connected in some way to your childhood experience, and repressed emotions, anger and fear being the most common, but unrecognized anger or fear, that's another long-term consequence of ACEs that can lead to a psychophysiologic pain or illness. So lots and lots of ripple effects there, let's say. Pain perception, those are simply studies that show that various psychological factors can have an impact on how you experience pain and how you perceive sensations coming from your body. My colleagues and I like to show when we're doing speeches for healthcare professionals and for the public was a picture that was published in the British Medical Journal in the mid-1990s. And this was of a construction worker who impaled his boot on a nail and went right through the boot, and the sharp point was sticking up out of the top of his boot. And he was instantly in agonizing pain. He was rushed to the emergency room. He was given morphine intravenously, and then the boot was carefully cut away. And to everyone's surprise, the nail had passed neatly between his toes. And he didn't have a scratch. So, of course, as soon as he saw that, he was fine. But it just shows the power of the brain to create a perception. And it turns out that's where all pain comes from. It's your brain creating a perception to protect the part of your body that has been injured so that you don't injure it more. If you didn't feel any pain from a nail that actually did go through your foot, you might make things a lot worse. So that's why your brain generates this. But it can generate it even when there's no tissue damage. And that's what these pain perception studies are all about. Lots of different factors that can go into whether your brain tells you that a particular body signal is painful or not.
It's interesting. I'm curious if any of these studies show two other factors, which I have talked about on the show before. One of which is that oftentimes those of us, I'll say us because it includes myself, who come from that controlling, perfectionist, overachieving type approach to deal with our emotions can also sometimes repress pain, right? To be in denial of pain happening because you're so out of touch with your body because you're shoving things down in order to be an overachiever. And my husband always says that I have the highest pain tolerance of anyone he's ever met. That it's complete aside, but I'm a redhead, and when I had work done, there's something about the Novocaine that is not as effective for me, and so I could literally feel the drilling and just, like, let them continue anyway and moved on. Um, and I think that and if I go to the hospital and they ask me on a scale of 1 to 10, your pain tolerance, like, I will always say a middle of the range, and they'll say, "But you're telling me you're in extreme pain." I'm like, "Yeah, but, like, I could have been stabbed or I could have been whatever. That would feel worse." But I think for most people, like, how they perceive pain is differently. And then I'm wondering also, we've talked about how medical professionals' perception of women's identification of pain is treated differently than if a man is saying that he's experiencing some kind of pain. Do any of the studies included address either of those approaches as well?
Yeah, you've unpacked a lot of ideas there, but yes, it's unfortunately true that women and their physical complaints are not taken as seriously as men. And that's also often true of people of color not being treated as seriously as they should. And many people initially, when they hear about the psychophysiologic concept, they feel like they're being dismissed and that they're being written off as this being imaginary pain again. And that's the opposite of what we're advocating. We're advocating that people actually have more attention paid to what's really going on beneath the surface, that the pain is, again, absolutely real, and that we need to identify the causes of it. And when we do that, those causes, those stresses, past and present, can be treated successfully. And when we do that, we see that the symptoms begin to improve. And that's really the proof of the diagnosis, that when a person's stresses are identified and treated and they start to feel better, that tells us that we're on the right track, even if it's going to take a period of time to achieve those outcomes. I've had patients who were ill for a decade or more that were cured in a 1-hour conversation. But there are other people that may need years of psychotherapy. But even those people, if they are making steady progress, they can see that there's light at the end of the tunnel and that they're getting where they need to be. So, bottom line is that this is a way to take a person's physical symptoms seriously, even when there's no biological explanation.
So you touched on the eighth pillar. So maybe we talk about that, the economics aspect of some of these studies and how that impacts, as you said, marginalized folk in general of PPD.
Yeah, the economics of this is that there are hundreds of billions of dollars spent on chronic pain. Something like 10 to 20% of the entire healthcare budget is around this condition, which is treatable. To make this real, I can just talk about one individual who had pain for 55 years. He was 74 years old when I saw him. This was back in the days before we had electronic health records. And he was accompanied by volume 3 of his paper chart, which was 3 inches thick. And I'm sure the other 2 volumes were just as thick. And they were full of negative diagnostic tests and unsuccessful treatments. And his story was that he'd been physically abused as a boy. And I sent him off to a class for adult children of dysfunctional families. That was the name of the class. It was 8 or 10 people with an instructor. All the people in the class had been through experiences similar to his. It was 2 hours a week for 8 weeks. In the third class, he felt comfortable enough to start talking about himself, and he ended up speaking for 40 minutes straight. And this was a man who worked as a lumberjack. He was not comfortable talking about himself, but in this environment, he did great. And by the end of the class, his pain was gone. But just imagine the amount of money in healthcare dollars spent on that patient over 55 years, and then just multiply that by 50 million adults in the United States alone. Not everybody obviously has pain for that long, but you can just imagine the healthcare dollars that are needlessly being spent on this problem when there's an outstanding solution available, as we've already seen in the Boulder back pain study and several others that confirm those results.
Well, and I think that leads to another kind of section of studies about ineffective treatments, right? Like you're talking about this individual who had numerous tests and treatments that were ineffective and how expensive that is on the system and money going into for-profit healthcare companies, but also that are hard on the body to undergo some of these invasive treatments. What are some of the studies referencing in there?
Yeah, there's a lot of them. There was one recently where they did a nerve block in people with back pain. And if the nerve block was successful, they would go ahead and ablate the nerve and expect that would produce long-term pain relief, but it did not. It was no better than a placebo treatment. And there's a lot of other examples like that. And Meniscal knee surgery is another one. You go in and you do a sham surgery where you stick something inside the knee, an arthroscope, but you don't do anything beyond just putting the arthroscope in there and having a look around. You compare that with going in there and doing the meniscal surgery, and the outcomes were the same. There was just a placebo benefit. The outcomes of surgery for low back pain, different kinds of surgery, different kinds of invasive treatments are absolutely abysmal. I think only 27% got improvement in one study, which is probably no better than placebo treatment. So, and that's not even getting into all of the what I call placebo predators who are advocating and selling spine decompression belts and medications, supplements, probiotics, on, things that have nothing more than placebo benefit for this condition. It's absolutely unconscionable that people are selling these things to this very vulnerable group of patients when we have pain relief psychology that is light years better than placebo comparisons in trials.
It strikes me as the snake oil references, right? And I like to hope that these individuals and brands have good intentions and that they genuinely believe that things are helpful. But this is where going to the science and looking at research and all of these kinds of things are so very important because we don't want to waste people's time and money on ineffective treatments. It just prolongs the pain and the suffering that they're in. So, listeners, I will direct you to endchronicpain.org for some of the other pillars you can look into yourself, predicting the clinical course, neuroscience, which is something we've talked a lot about here, other adjunct treatments. So there's clinical papers. I think I heard Dr. Clarke, you said over 230 at this point in this bibliography, and we'll put a link in the show notes for you to that particular um, resource of your website. I would love if we can talk a little bit about some of the people who might be great candidates for this, right? So we've talked through what all of it is, but if there's a listener who they themselves are thinking, could this be right for me? Or maybe they know a loved one who's been suffering with some of the conditions that you mentioned for a long time, what would their first step?
I'm so glad you asked that because it's something I intended to talk about with you today. And we have a 12-item self-assessment quiz on the website. It's at endchronicpain.org. It's very easy to find. And I spent a lot of time refining that down. My initial self-assessment quiz had 37 questions on it. And my internet guy said, "You can't do that on the internet. 37 questions. Are you kidding me?" So he said, "You got to boil it down." So I spent a lot of time trying to pick out the absolute 12 best questions that would help somebody self-assess whether their particular pain or illness might fit in with this category. It's not intended to be diagnostic. It's just a screening test, but each question comes with a sentence or two of information about why the question is in there and what the question means. And it's set up and worded in a way that the more of those 12 questions to which you answer yes, the more likely it is that you will have benefit from the psychophysiologic resources on our site.
Super helpful. And I always like to leave listeners with something positive or actionable that they can take forward to be of service either for themselves or for others. I know we've talked about a lot of different options and resources, but what are some things, if you were thinking to yourself about all of the patients that you've helped and what like their positive outcome and the life that they're living in a joyful kind of pain-free, hopefully experience, what are some of the things that you associate with that maybe those of us listening can embody and take forward and not feel like overwhelmed with all the things and need to go take this test and then I need to go do these classes and blah 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 blah, right? But like what is something that we can walk away from listening to the show today and being like, I can do that. I can help myself. I can help somebody else. I can do that.
Yeah, we have half a dozen or so video recorded interviews on the website that people can watch and hear the stories of people who have been through this journey and come out the other side. So I think that's a simple thing to do that will give people a lot of hope. But another idea that is very helpful is for people who went through adversity as children, for people who had experiences they would never want for a child of their own. An important mental shift in how you think about those experiences is to imagine them analogously as having been born in a dangerous wilderness or in the middle of the Himalayas. And through no fault of your own, you found yourself in this very difficult environment that took heroic perseverance on your part to get through and emerge from on the other side. And if people can think of their ACEs experience as a hero's journey, as not that they were a second-rate human being as they may have been made to feel, but that in fact the opposite is the case, that they have done a heroic thing by coming through that experience and coming out the other side, and think of themselves in those terms. That begins a 180-degree flip in your self-image that is fundamental to everything else that we want our patients to do.
I love that. Appreciate it so much and appreciate your time. Listeners, I want to remind you, you can find Dr. David Clarke and his work at endchronicpain.org, and we'll put links in the show notes for you. You can also find the PD Association on social media, and we'll put links in the show notes for you, but you can just search PPD Association and they should come up on whatever platform you're looking. And I also want to thank you for your time in listening to the show today. And if you enjoyed the show, to please leave a review. It costs you nothing but a few seconds of your time and helps us continue to do this work. And don't forget to subscribe in whatever app you're listening. As always, we appreciate your willingness to be open to grow through your own personal change. No one is perfect, but in listening, learning, and unlearning, we can choose to become better versions of ourselves for ourselves. Dr. David, thank you so much for your time and sharing so much of yourself to this cause. Was there anything else you wanted to add for listeners before we part ways?
I will just say that if any of your listeners are suffering from this, there is tremendous hope. Patients of mine with symptoms for decades, one of my patients with 27 different symptoms, people in the hospital with this, people with paralyzed stomachs or bowels, all kinds of severe symptoms have made full recoveries.
I love ending on such a positive note. Thank you so much.
Thank you,
Thank you.
Stacy.